Well, welcome. My name is Linda Ball. I'm the Quality Improvement Director for Northwest Renal Network, and today's topic is assessing gas maturity. So please mute your phones by pressing *6. Most common stenosis for cellular maturity, of course, is the inflow stenosis, or it's better known as the juxta-anastomotic stenosis, or the JAS. Juxta means next to, anastomotic means it's next to where the surgical connection was. And so the area, for instance, in the wrist, there's about a 3-inch segment right along here. This is called the juxta-anastomotic region. And if you palpate the access at that point, in a fistula that's not maturing, you should be able to palpate a flat spot there. And so that's one clue. The other clue is that, you know, your fistula is not getting bigger and your walls are not getting firmer for you. There's no rebound when you press on it. So it prevents arterialization because we have the two vessels, and the two vessels, the artery and the vein, have to both grow in diameter in order to accommodate the higher blood flow rate. And it's those high blood flow rates that cause the walls to dilate and to thicken. And for the most part, it's due to surgical technique. When they swing the vessel over and connect, sometimes they're using clamps. So the clamps sometimes damage the walls, and so they don't open up and they don't stay open like they should to allow that good, hard, high-pressure flow to come through there. Now, you can see right here in the circle, this real tiny area, that is a juxta-anastomotic stenosis. And so we really need to have that open because we're not going to develop anything that's usable when it's this small, because we need that flow to come over here. And then you can see afterwards, after they did an angioplasty and put a balloon in there, they increased that and able to have that flow increase. What are some of the other causes of non-development? Well, it's all about location, location, location. You need to have appropriate heart function to be able to deliver that high flow of blood. So if somebody's got low ejection fraction or their heart has been damaged so that they can't squeeze and forcefully send the blood throughout the bloodstream, then forearm fistulas at the wrist are not going to develop very well because there's not going to be enough pressure because the forearm access is the furthest away from the pump. And so we need to make sure that we can get pressure all the way down there in order for that access to develop well. Your upper arm accesses will usually develop in spite of an ejection fraction. They have a better chance of success with the chart, and that's just because they're closer to the pump. Diseased vessels are another problem, and that's why we encourage, Fistula First encourages, and why we've now been able to get vessel mapping paid for vascular access, because that way we can see a diseased vessel. And we won't just open up a patient and look in and say, oh, well, these vessels are bad, I guess we're not going to go there. Or, oh, well, we'll make one anyways and see what happens. We're beyond that now. We are beyond that now. We have the technology to be able to identify good vessels that are not diseased and locations, and so we can make much smarter decisions than we've ever had in the past. For cardiac output, we've talked about that. And that's the ability of that to be able to eject a good volume of blood under a good pressure for us. Accessory veins. We will show you what those accessory veins look like. Right here, you can see this fistula here, and you can see these are offshoots. And these are pretty big vessels to be able to see and to recognize. And what happens is that we require pressure to enlarge the fistula, and what happens is with these larger accessory veins, it bleeds off some of that pressure. So these are what we call the exit ramps. So the blood just goes through and gets off these exits here, and then it leaves less pressurized blood volume in those fistulas in order for us to develop those nice strong walls. So what can be done with these? Well, typically when surgeons open up a patient to create this, if they see them at the time, they can tie them off with some silk. Then we won't have these to worry about at all. But some of the other things that they can do is they can, after the process has occurred and it's developed or it's trying to develop but not able to, they can do what's called coil embolization. And this is what it looks like. Here's the coil, and you can see all these little, I like to call them the frayed ends. Well, they can feed it right into a vessel that they're trying to clot off. And the purpose of these little pieces that are sticking out is that they're sticky and they affect the platelets. So as they feed it into the vessel, then it goes in. You can see it nice and straight. As it goes in, it starts to curl, and it curls up even more. And by the time they get it all deployed, it has filled up the diameter of the vessel. And then, of course, it attracts all the platelets, and then fibrin forms, and then you have a clot, and it clots off that extra vessel. So that's something that they can do now where they don't have to go back in and open up the patient. They can feed this in right in through the fistula. And what you might notice is that sometimes if you're palpating around the fistula, you might be able to feel the coils. They might feel like little hard spots. You might also notice that right after the procedure, they might have reddened areas. And that's kind of an inflammatory response, and that usually will go away after that. So what is it that we need? What are the requirements for cannulation? Because now we know that we need to have some kind of requirement. And over time, now that we're looking at it, now we're getting more and more research. We've got interventionalists. Dr. Robbins, she is an interventionist from the University of Alabama at Birmingham. And what she's seen over the years of looking at vascular access for dialysis patients is, number one, we need a vessel diameter that's going to be able to support our big needles. We don't use these type of needles typically for surgeries or anything like that. We use much smaller gauge needles, so they fit into our regular normal size veins. But now that we require a blood pump that's going to actually pull blood out of the patient's system, we need to have those larger diameter needles. So what they found out is if the diameter is greater than or equal to 4 millimeters, the chance that it would be adequate dialysis was 89% versus 44%. And we also require to have blood flow through that fistula. And it has to be at least a minimum of, a certain amount of blood flow. So she found that if it was greater than or equal to 500 mLs per minute, the chance that it would be adequate was 84% versus 43%. So you can see it's almost doubled for the reasons that we need it. And if you combine those two variables, so that we have vessel diameter and blood flow, the chance that it would be adequate is 95% versus only 33%. So that's why we focus so much on saying we need to have a particular size artery and a particular size vein, and then we have to do those flow studies. That's why you're doing flow studies on your patients on a regular basis. Make sure that we can maintain that. We also know that we need to have at least 100 cc's more blood flowing through the fistula than whatever pump speed we are desiring or have been ordered by the physician. So in other words, if we only have a 500 blood flow through that access, we can't get any higher than a 400 blood flow, because at that point our arterial pre-pump pressures would be so negative that it would cause massive hemolysis, because we'd just be sucking so hard. And so that's why we've got these variables have come up, and why we've got these guidelines to guide us. So what else did they find? Well, that blood flow through that access occurs really early after we have the surgical creation. And what that means is in post-op weeks 2 and 3 is when we have the maximum amount of development occur in an AV fistula. so that by week 4, if you don't see any development of that access and it doesn't look any different than the day it looked when they got out of surgery, then you're not going to see that access develop. And what she looked at, she said there was no significant difference in fistula blood flow in the 2nd month, the 3rd month, or the 4th month after fistula creation. So when your doctor says, well, we'll give it a month. Well, we'll give it a month. Well, it looks like it's improving. We'll give it a month. She found that there wasn't any more increase in blood flow and there wasn't any more increase in diameter. So it's not going to develop at that point. And the definition of a failed fistula is if you're not able to use it after 3 months after creation, then it's considered a failed access, a failed fistula. So we don't want to do that because we then make our patients at risk for keeping that catheter in for a longer period of time with no further progression in there. And so some of the most current research says that we need to be more aggressive, and what they mean by aggressive is that we need to refer earlier in order to make sure, because our assessment alone now is not going to tell us what's wrong with that access. It just tells us there's something wrong with it, but it doesn't tell us what. So we need to get it back to either an interventionist or back to the surgeon so they can look at either the Doppler flow studies or they can go in and they can do an angioplasty and an angiogram, a fistulogram, and perhaps an angioplasty to open that up. Because nothing that we can do as patient care staff can open up a juxtaanastomotic stenosis. That has to be done from the physician side. And so when they say aggressive, they mean refer earlier. So at 4 weeks, if there's no development in that access, that's the point where we need to get them referred, because any intervention that they do at week 4, it will take a couple of weeks to see something change, and by maybe 6 to 8 weeks, we'll be able to use that access. Now, Torgwad did a study in 2003, and what he found for his AVF maturation flow study, he looked at a radiocephalic fistula maturation, so that's the forearm fistula. And what he found, the early flow in the fistula at day 1 was 754. In 7 days, it was 799, so that's 1 week. And at 42 days to 6 weeks, the flow was 946. So you can see that right between, 1 week, it was substantial, but it increased, substantially within weeks 2 to 6. So let's take a look at the nursing assessment. And what you need to do is every single time that patient comes in, that access that's maturing needs to be assessed. And I know on your daily run sheet that there's no place for you to put information on an access that you're not using. So you should go to your nursing notes and your progress notes, and you should be writing something about that access. And if they've got a dressing on, we need to make sure that it's dry and intact. You need to check your surgeon, because some surgeons do not want anybody to change those dressings but them. So you need to find that out first. But we want to make sure that it's dry and intact. If we see drainage on that dressing, we need to describe what that drainage looks like. And what you really should do is you should outline the drainage and date it, time it, and initial it, and then put it in your notes, because they might have a slow leak and it might be getting bigger and bigger and bigger. But if we haven't initially identified a time and a date of when we saw the initial drainage, we won't know that it's progressing. And that's one good way to tell without taking that dressing off. And if there's substantial drainage on it, we may need to call to get permission to get that changed or to get them right in to see the doctor. We want to be looking for swelling, because with the creation of AV fistulas, we shouldn't see traumatic kind of swelling that we see with graft placement, for instance. Because remember, they have to create a tunnel in the skin for graft, and that's what causes a lot of the tissue trauma and the swelling. So you want to look for any color changes, for any kind of boosting, and you want to describe the amount. And then you need to ask them for symptoms. You know, we want to check their skin. We want to check their temperature. We want to check and assess their pain level. That's really, really important for us to be able to document, because then we've got the evidence to get back to the surgeons if we want that patient referred back. Then we've got these real good concrete reasons why. And then do an overall skin assessment of that access. Auscultate, you need to listen. You need to check that early. And remember, it's a low continuous sound. It's that whoosh. And we want it to be a good sounding flow, like it's really rushing through there. And so the patency, yes, whether it works, the quality, the good sounds of it, and the character. You know, is it a continuous sound? Is it a choppy sound? Is it kind of weak sounding? If it is, then that's foreboding of that access. That access may be dying. And so that's why it's really important that we check it every single day. And some facilities teach their patients on how to listen with a stethoscope, and some don't. And that's okay. We really need to make sure that they are checking it, though, and we need to make sure that they're palpating. So we need to teach all patients how to check for thrill. Now, remember, the thrill should have one of two sensations. It should either be a vibration or a purring. It sounds like just a big boom, a pulsation. You know, that tells me that there's a problem with that access. And if it happens that quickly, then it's probably going to fail quite soon after their surgery. So the thrill tells us that it's patent. The quality, again, it should have a good firm sound under there. Whatever the sensation is, it shouldn't be a weak sound or a sensation. You should be able to really be able to feel it with your fingertips. And so you can you need to describe what the sensations are that you're feeling. And then the vessels, it's a good idea if you mark somehow the outside edges of the vessels, and we'll show you that in a few minutes, what I'm talking about, because I think it's important. I know that not everybody has the same staff taking care of that patient with the new fistula every single day for an entire month. And so the first month is critical for this. And so we need to have some objective way of looking at that access going, this is doing really well, or this isn't doing really well. So we want to document the diameter at baseline. We want to document that pliability. And what I mean by pliability is when I touch it, is it mushy, like my veins are now if I were to touch my veins? Or can I feel it? Can I outline where that fistula is with my fingertips and feel that because the wall is starting to thicken? You also need to assess for the curves and to make sure there aren't any flat spots, especially around the juxta-anastomotic area there. And then, of course, the depth. So those are all the things that we want to be feeling for. Even on an access that we're not using, it's really, really important. After the first week, we want to let the anastomosis heal for that first week. But after that first week, you might want to put a light tourniquet on and see what it feels like and see if it's starting to develop. So what is the nurse's role? Well, you need to assess that new access every dialysis treatment after they have their surgery, and you need to document that in the progress note every treatment. It's not appropriate to talk about the patient in the break room and say, that, well, it doesn't feel very good, or, well, I don't know, I didn't check it. We need to be documenting this. This is really, really important. Remember, this is going to be their new lifeline. And so from day one, we have to make sure that we are communicating to people about what's going on. And then if anything that's unusual, so if it's thready or if it's bumpy, we need to report that. And if you have a vascular access manager, that's the person to report it to. And then that will contact either the nephrologist or the surgeon to get that patient back into evaluation. So after 1 week, we also want to get started on some exercises because that's really important. At least 3 studies out there that show that when we do exercises, we increase the flow through there with presses on the walls. And when we press on those walls, it starts to fall, and it sustains dilatation of the blood vessels, even after they stop exercise. So it's really good to start doing that. And so Dr. Robin, the interventionist, she also followed some experienced dialysis nurses and had them do assessments on new fistulas, and she found that 80% of the time they could identify when that AVF was mature and ready to cannulate. I think we can get that higher if we improve our assessment skills, and actually we can learn to differentiate using our fingers and our stethoscopes about how well those walls are developed. So let's talk a minute about the new fistula versus the mature fistula. And are they different, and do we really need to have the expert people dealing with brand new fistulas? And the answer to that is absolutely we do. We need to have some criteria in facilities that identify expert cannulators, not necessarily people who've been in dialysis the longest, because that does not add to your expertise or your clinical skill set. Although it does have a lot of experience, but some people don't take advantage of their experience that they have. And so we don't usually use that as criteria, but we want to know that you've got the best assessment skills for the patient that you're focusing on. So, I liken new fistulas to newborn babies and mature fistulas to 2-year-olds. Now, if you look at this picture, you see this baby, and you see that somebody has already given this father some instructions. The first one was you need to protect the head because, there's damage that can possibly occur if you're too rough with the baby. And something can happen to our new fistulas. We know nothing about new fistulas, just like we don't know much about brand new babies, because they're all individual. And so we have to, a lot of times you'll touch the baby to see if there's any kinds of problems and things like that. So you need to touch that fistula, and you need to treat it just like it were a brand new baby. There's no roughness. You really have to pay attention to the, and I don't want to call it idiosyncrasies, but the differences that, the baby can express themselves in only a certain number of ways. And you have to have those clues to pick that up. And the same is true with fistulas. And you need to watch the patient, watch the physician. You need to be doing a lot of explanation. We talk a lot to newborn babies, and they don't talk back to us or answer us, but we still will do that. But they're very gentle. And you have to be very, very gentle with newborn babies. And not all of us have the skill set to take care of a newborn baby. There's certain things like, when to feed them. I mean, you can put them on a schedule, but what happens if the baby cries in between the schedule? Does that mean that they're hungry and I have to feed them now? Well, if I'm not interacting with newborn babies on a regular basis or don't have any myself, I don't know that. So I'm kind of guessing. And I don't want to be guessing with a newborn baby. I want to have that confidence to know how to take care of that baby the right way. And the same is true with any fistula. You can't guess and say, I'll give it a try and see what happens. That's not the way we want you to, we don't want your mind in that state. We want you to be confident. We want you to assess it. And if you believe that this access is not ready to cannulate, then we want to know that you know enough to say, it's not ready, I can't do it. When we talk about mature fistulas, here's this 2-year-old wrestling around on the floor with Dad. They're pretty resilient, and our mature fistulas are very resilient. We can have anybody take care of a 2-year-old, and we might all take care of that 2-year-old in very different ways. We have very different skill sets to take care of a 2-year-old, but the 2-year-old survives until Mom and Dad come back. All right, and so it's okay to get people with different skill sets, although we would like them all to have really excellent skill sets where the baby never gets hurt, where the 2-year-old never falls down and cries, where, he doesn't get bored or anything like that. And we would like everybody to have those really good skill sets, but the fact of the matter is not everybody has, all their skills to take care of a 2-year-old, but they can. Now, with some of our staff in our facilities is that we've got some people that really don't have the best cannulation skills, although they can get by, I don't want you to just get by. I want you to get better. But we can have people that do things differently but still be successful with mature fistula. That's not the case with a new fistula. We need to have that excellent skill set to go along with it. So, how do we know whether or not it's ready? Well, there are maturity characteristics that we can look at. And, of course, we talked about that pliability. So right now, if you look at your veins on your hand, for instance, your veins, when you touch them, they're very soft. You really can't discern much of wound heads, the boundaries of it. And when you press on them, they're just kind of mushy. Nothing pushes back at you. That's what we mean about soft and pliable. But we want it to be springy and firm. When I put my fingers on a fistula, I want to be able to feel it. And when I press on it, I want to feel it pushing back. It's almost like saying, get off of me. And that's what we want. That's what we're talking about springy and firm. And remember, we want that vessel to double in size. So we're looking at, hopefully, the smallest vessel they'll use is a 2 millimeter. And we want that to develop into between a 4 and 6 millimeter vessel, because that's where we'll have a large vessel when we put our needles in, that we won't have a lot of pressure problems. And we won't have a lot of machine alarms if we've got an adequate vessel for the size needles that we're using. And when I talked about the margins, you can see the vein right here. When they come back from surgery, just take a Sharpie, a permanent marker, and put a little mark on each side on the outside edge of the vein wall, because we want to see this vein outgrow this area. So when we look down here, 4 weeks afterwards, here was the original. Now look where the edges are. That tells me that, yes, it's doubled in diameter there. And so that's one thing. And then as I press on it, we can tell, because it looks different, that when I press on it, it should press back for me. And so that's what we want it to look like. And that way you can document this every treatment. Because if it doesn't look any different than this at the end of 4 weeks, there's no way that we're going to be able to use that. Waiting and waiting is not going to do anything to make it look like this. All right? So, and then, of course, you assess the thrill. We want it to be strong, but we also want it to be non-pulsatile. That means no bass drum sound, no thump, thump, thump. It's either got to vibrate or it's got to purr. And then the bruit, of course, needs to be low-pitched and continuous. If it's discontinuous, that means it's choppy. And one of the things that's really, really important for you to understand, if you want to ever cannulate brand new fistulas, if in doubt, leave it out. You know, a doctor calls up, you say, wow, the catheter's clotted. And you call the doctor and tell him that. I've got a new fistula, just stick it. We should have already done that assessment on that new fistula and said, you know, in my opinion, it's not ready. It's not mature enough to put needles in. Oh, stick it anyways. No. Based on this, it's still soft and pliable. The diameter, we marked it initially, and it's not outgrown that very much, so the diameter is not increasing. So even if we could get the needles in, we're not going to get any kind of blood flow rate out of it. And then you'll describe to them what the thrill and brewing sound like, because it shouldn't be strong and non-pulsatile if it's not developing. It should be kind of weak or spready sounding, and you're low-pitched, and it probably will not be a continuous sound that you hear. So, my response would be to the physician, in my opinion, it's not ready to cannulate, and I think that you need to do an evaluation on this before anybody puts a needle in, because in my opinion, if you put a needle in it now, it will infiltrate, and the patient will still have to have their catheter fixed. So we're trying to teach pathologists and surgeons that if we say it's not ready to cannulate, and we've got the expert cannulators there, then they need to listen to us, because we have the expertise when it comes to putting those needles in and putting it against a blood pump. Putting a needle in is one thing, but putting a needle in and then trying to suck blood out and push blood back through, that's a totally different thing when we're using pressures. And those are high pressures considering the system that we're in. So some of these exercises that you can do for forearms, we need to do different exercises for forearms than we do for upper arms. So our forearm exercises have to do with squeezing the hand, and you can use the toys, you can use the kidneys, the balls, you can use a washcloth. You don't have to do anything. The mere fact of you just squeezing your fists together works to help dilate vessels in your lower arm. Or when you're using your fingers against your fingers, as in this picture here, just doing that over and over again also helps for forearm fistula. When we're talking about upper arm accesses, we need to do some kind of curls because that's the only thing that will work on the biceps area in the upper arm. And, you know, we don't want them to have tremendously heavy things, but it's a motion of it makes the really tight fit and work doing the curls. As long as they can feel their muscle in their upper arm when they move their arm back and forth, then they will be having some impact on that vein. We've got one surgeon from the Midwest, and he says he gets excellent results by having the patient use their finger and to come right above their access for 5 seconds, and then to release their finger. And then he said great success, simple development of the fistulas by doing that kind of an exercise. One of the things I want to say is that if your access isn't maturing because of a juxta-anastomotic stenosis, it doesn't matter how much exercise that arm does. It will not develop just on exercise alone. Exercise is an adjunct, or it's in addition to having a nice open vascular system that will allow arterial blood over and develop that side, the venous side. So we've got more and more facilities now going to a staff rating system. And I think this is important, and I think you might need to look at this in your facilities. The Fistula First Breakthrough Initiative, we developed a 4-level staff rating system, new, novice, intermediate, and expert. So you're a level 1 cannulator if you have no experience. So you're a new person, and you're coming in and you're in the training program. And that's where you learn your cannulation skills. You practice in the training room. You don't practice on patients. Nobody should ever be practicing on patients. There's lots of training devices out there. There's all kinds of arms that can be used. You can use, people have used sausage with blood tubing put in them and turkey legs and things like that. You can use the blood pump segment for cannulation training. That's good because you can see about your angle of insertion when you use that segment. It's a little fatter than the rest of the extracorporeal circuit. So that's the only place where you're putting needles in is in the training room in the practice setting. You learn how to tape. Everything you need to know about vascular access and explaining your rationale and learning goes on as a level 1 in a training area. Level 2 would be for graft cannulation only. So you would set up, for instance, that you would have to successfully cannulate 5 grafts. And successfully means getting 2 needles in, no infiltrations, and the ordered blood pump speed for that particular patient. When you successfully are with the educator or a level 4 expert cannulator, and they can document that you did it correctly for 5 times, then you become a level 2 cannulator. And that means that any graft in your facility, then you can cannulate. To move up to a level 3, then you would have to do the same scenario, 5 accesses, mature fistulas, 2 needles, no infiltrates, ordered blood pump speed. And when you master that, then you become a level 3, and you can do all mature accesses and graft cannulation as well. Now, what you need to do is you need to identify what is a mature access. Is it 6 months or is it 12 months? And identify what's considered a mature access in your clinic. So that way there's no question about who's got a mature access and who doesn't. And then to be an expert or a level 4, then you have to either come back with your educator or with another level 4 person, and you have to cannulate 5 new accesses under the same criteria. 2 needles, no infiltrate, and the ordered blood pump speed. Now, we know that that's a smaller blood pump speed and a small needle gauge size. So that's, you're still given an order about how to start, or your policy and procedure still should describe to you that you start with a 17-gauge needle at a 200 or a 250 blood pump speed. And if you can successfully do that with new patients, then you become then the expert cannulator, and that means you can cannulate all of them. The level 4 should also be those complicated accesses, the ones that require multiple sticks on a pretty frequent basis. Those should be reserved for expert level cannulators as well. And again, if the experts are having trouble with it, I don't think it's the cannulator's problem. I think it's a vascular access problem that the surgeon needs to address. All right? And so, again, your competence ratings are done either by the educator or by a designee that is a level 4 cannulator. So, let's talk about some tips for more successful cannulation. I rarely say never and I rarely say always, but you always need to use a tourniquet on an AV fistula. I don't care how old it is. I don't care how big a round it is. Or I don't care how good you think your skill set is. There are really good rationale for you using a tourniquet. It firms that access. It plumps it up. You can see it better. You get a good feel of it so that you use the correct angle of insertion. We're damaging a lot of accesses because we're not using the correct angle of insertion. And this will decrease the risk of infiltration. And you've heard it before, and facilities in Network 16 all receive this particular picture, and I call it Plump It Up, and this is the no tourniquet versus the tourniquet. And if you take a look at this one over here, when you put a tourniquet on, it backs blood up into the vessel, into the fistula. And what it does is it puts pressure against the walls here and causes tension on the walls. And we know that stretching the skin taut allows needles to go in with a lot less pain. Well, it will also allow it to go into a vessel wall with a lot less pain. And when you've got that needle halfway in, look at where you are. You are in the center of the blood vessel. You're nowhere near the back wall where you can cause a problem and infiltrate or cut the wall. And by definition, we want to be in the center of the blood vessel wall, and that will prevent us from damaging the lining. It will decrease the number of alarms that we have because of our cannulation technique. And so our patients should be able to get better flow rates as a result of that as well. Now, when we look at the other picture, there is no extra blood coming in and plumping up the walls. Actually, when you put the needle in, the pressure exerted on the wall here, because it's not there's not a lot of resistance there. The pressure comes inward this way, and it actually pushes down, and now your vessel's not round anymore, but it's now becoming oblong. And when I'm halfway in, I'm pretty close to the back wall. If I use an incorrect angle, if I use too steep an angle when I come in, I will be to the back wall, and I could potentially be through the back wall. So this is the back of the wall. And so we want to make sure, and it requires more push to get through here because this isn't a nice taut wall here. It's not tight. So then you have to really put the brakes on as soon as you break through here, and you feel that sensation of release of decreased pressure, decreased resistance. You have to make sure you stop really quickly. Otherwise, you're to the back wall before you know it. So that's why we want to use a tourniquet all the time, because it prevents us from getting there and causing any problems, especially on our brand new, fragile, unknown fistulas. It's really, really important. And remember, we want to decrease the pain, because this is a new experience for the patient if this is the very first access that we're going to put needles in, but we also want to make sure we anchor the vein in place so that it doesn't roll around, because that's another reason why we have infiltration. That vessel moves, we continue to insert that needle, and we can come out the side wall, the back wall. If we're holding it in a different way, we can also come through the top wall. And I've seen that happen. So with pulse ladder technique, we want to retract the skin backwards this way. And on the buttonhole technique, we want to retract from side to side because we don't want to stretch the skin back this way because when we let it go, the skin will come back where it was originally, and it will cause our tunnel to be, we'll end up with a Z tunnel, and we don't want to do that. But we do want to make the skin nice and taut because that does decrease the pain. It allows the needles to go in with a lot less pushing on your part. And even if it's not pain that the patient feels, they can feel a pressure. And it's scary when you feel that pressure. Your angles of entry is another good, important thing in order to prevent cannulations. Now, when I was at cannulation, you cannulate between a 20-degree and a 35-degree angle. And it's not the same for everybody. You cannot use one angle of insertion for all patients. Our venous systems are all at different depths. Some are above the surface of the skin, some are very deep below the surface of the skin, and then others fall in between that. But the way you identify it is to put your light tourniquet on up in the axilla area, and then you palpate that vessel, and then you determine, and this comes from practice. This is why you have to do lots of cannulations and pay attention to what you're doing in order to get that expertise of saying, oh, yes, well, when it's there, this is the angle that I use that I'm successful at. Because if you over-rotate, you're through the back wall and you're infiltrating before you know it. And so we really don't want to go any deeper than a 45-degree angle on any aspect. And then when you have this increased pressure coming up there and it takes longer for accesses to clot. And so when we've got these less deep pressures here, the surgeons say that the vessel collapses nicely, and there's less pressure trying to force its way up this hole, and so the clots form faster. And you need to know what angle you're going to use before you cannulate. You don't go in and then start changing the angle because you'll be pulling back and pushing in, and you kind of make mincemeat out of the tissue that's surrounding that. And that causes a lot of pain, and that also causes a lot of bruising. Also, if you over-rotate your angle of insertion, you can stretch the opening in the surface of the skin, but you also stretch the opening into the blood vessel. And then when you heparinize the patient, they can ooze out into the tissues during dialysis. And they come back that next day, and they're all bruised. And what do we say to the patient? What did you do to your arm? It looks so awful. Well, it could have been something that we did to the patient and caused that bruising because they look at you like, what do you mean what I did? I didn't do anything. And they truly may not have done anything. It was probably what we've been doing, and now we have to just pay more attention to that. Now, clamps versus holding sites. On brand new fistulas, never, I repeat, never use clamps. There is no way to adjust those pressures appropriately. That access is very fragile. That tissue has never been handled that way before. And so we need to make sure that we get good clots on there. And with fistulas, we don't want to go from a compression state to a decompression state. In other words, we don't want to press down on it and then all of a sudden just release our fingers like we do with our clamps. Because when we open up a fistula, that blood increases, that flow increases through that fistula as soon as we snap it open, and it can rip that scab right off and cause rebleeding. We've also got a lot of our patients come off hypotensive at the end of their treatments as well, and so putting clamps on while they're hypotensive, and we stagnate that flow, that we can cause accesses to clot off. And for new fistulas, it's 10 minutes, no peeking, no exceptions to make sure we've got complete clot formation. Those patients probably don't have the best education about how to stop a bleed once they get home because it's new to them. And so it's really important that we make sure we get a complete clot to form on that access site. So holding it for 10 minutes ensures that occurs. And again, capillaries break very easily, and this is a picture that shows the two holes that we make. Here's the surface of the skin, here's the hole that goes into the blood vessel. And so when we do hold sites, we need to use a two-finger hold. One finger goes over A, one finger goes over B, and that way we secure and have the best clot development here. We're always so focused on this one that sometimes our finger doesn't come over and cover this one up. This is where the blood is coming out at. So we need to have two-finger holds, and we need to teach those patients right away that we do one side at a time, and they hold those sites in order to get good clot formation. So when we cannulate new fistulas, you need to have a physician's order to cannulate, and then you need to have the qualified, experienced person who can deal with all access types, who knows how to appropriately do an assessment, who knows enough about their skill set to be able to say, no, I think I'll infiltrate this. Because if you stuck it and you went, darn it, I knew this was going to blow, then we shouldn't have done it in the first place. All right, that's what I mean by knowing your limitations and saying this isn't ready. We're going to use 17-gauge needles initially. You know, gauge sizes have pressures associated with them. We use those small gauge sizes. We use smaller blood pump speeds, so there's less pressure going through that access. And you might want to ask the physician about decreasing the heparin dose for the new treatment, for that new start, by about 50%. But knowing that you'll probably have to supplement it with saline flushes. This is to help kind of reduce that oozing that might be occurring into the tissues and that big, awful bruising that you see on patients when they come back and their whole, half their arm is dark purple the next time they come in. You're always going to use a tourniquet or some kind of vessel engorgement device. That is your hand. Now, where your patient, teach your patient to compress their vessel, not occlude it, but, slow to slow, back it up so that you can get the needles in. Remember, no clamps, manual pressure, 10 minutes. And if a patient has a catheter, and we're going to use one limb of the catheter and one needle, we're going to use the arterial as the needle stick. We're going to pull from that access, not push into the access. And the recommendation is by K-Doki and by the Fistula First Breakthrough Initiative. I know when I started dialysis, we always used the venous one because we were going to help it develop. Well, we don't help it develop. We help create some of the biggest infiltrates you'd ever want to see in patients' arms. They cause massive hematomas. And remember, it's not about anything external to the vessel that develops it. It's about the arterial blood flow and that pressurized blood flow coming through the access. So we're not helping at all. We can only cause damage by using the venous needle in the fistula. So we want to use the arterial needle because if an infiltrate does occur, we're pulling blood away from the site. We're not pushing it in. Arterial pressure at that 200 tells me how good that access actually is. So there's a lower risk of complications. And remember, we always look at the risk versus the benefit of doing something. And using the arterial needle in the new fistula has the lowest risk of complications of the two. Now, if it infiltrates in the new access, K-Doki says that we need to let it rest until the swelling is resolved. And these are the 2000 guidelines. And I like these 2000 guidelines because they're much more specific about what we should do with our new fistulas. It says to let it rest until it's resolved. If the fistula infiltrates a second time, they say wait 2 weeks or until the swelling is resolved and call the doctor. If it infiltrates a third time, of course, we have to involve now the nephrologist and the surgeon. And nobody cannulates anymore until we get the word by the nephrologist or the surgeon. So they have to go in and take the internal look by doing further testing on that access. Then in 2006, they updated the guidelines. And it said, let the fistula rest for at least one treatment. And if unable, the next cannulation should be above the site of infiltration. Well, I'm sure that you always look above the site for that anyways. And then if the patient still has the catheter, restart the use of the fistula with one needle. So we go backwards and we start with the one limb, one needle. And then we advance to 2 needles and continue to watch for infiltration. So those are kind of guidelines that you can utilize. And infiltration instructions for patients should be written out so that they know what they're supposed to do because they won't remember We remember because we do it day in and day out. We know what to do. We know what to do. We've been taught that. The patient hasn't. They don't have that experience that we do. So write it down to them and explain to them what to do. The ice for the first 24 hours, 20 minutes on, 20 minutes off. When they're laying down, prop their arm up on a pillow for a little bit. They may not be able to sleep with it elevated because their arm may go to sleep. They're going to drain the blood out of there. That's not a good idea for them. While they're watching television or something, if they're lying down, make sure they raise their arm above the level of their heart so that they can drain some of that extra fluid out of there. So, because our goal is we want to get that access started, we want to get that catheter out of there. So once the patient's had 3 successful treatments, then the nurse needs to get an order to have that catheter removed. And what does successful mean? 2 needles, no infiltrates, and achieving the prescribed blood flow rate. The 3 treatments in a row. If you can do that for a week, then chances are that access is now sustainable over time, and that's why we think that it's okay then that we can get the catheter removed. So in summary, we need to improve our assessment skills for new accesses. You need to improve your cannulation skills overall. If you identify a weak spot in your cannulation skill set, go back to your educator or go to somebody who has that expert skill set and say, can you give me some pointers and tips on how to get better at what I do? We also want you to remember to refer failure to mature accesses immediately. So if we're hearing things and feeling things right off the bat that aren't good, that they're not normal sounds, you refer immediately. But at least at the 4-week mark, if nothing's going on, and that patient needs to be seen at least by the 6th week by their surgeon again to get the release. Because some people do it differently. Some have the surgeons give them a release for cannulation. Some the nephrologists say it's okay to start cannulating. And some the staff are allowed to say we think it's time and tell the doctor and the surgeon that they're going to do that. And remember, if in doubt, leave it out. Because research has also shown us that if we continue to cannulate and infiltrate, we can kill that access. And then the patient won't want another fistula, and they'll lose out on the gold standard. And then we need to communicate with the interdisciplinary team about what the patient needs. So, continually talk. You talk through your vascular access manager who will talk to the nephrologist and the surgeon. So, cannulation resources, here is the network website where you can find all of our cannulation resources. And the fistulafirst.org website, it's change concept number 8, that's cannulation training. So now we've got a few minutes. If you've got some questions, remember, don't identify yourself or your facility, just ask questions and hit the *6 key, and that will open the line back up for you. And I want to thank you for joining me, and there'll be a short poll that's on the screen right now. Before you hang up, please answer the poll questions, and thanks for joining me. So now, if you have questions.
Yes. One of the issues we have in our unit is that we need to get an order from the surgeon to use accesses. Even though we follow up patients' appointments, it takes a long time for them to get to that appointment, which prolongs the catheter use. So, and at the same time, also, we could not even touch that arm until the patient is seen by the doctor. And after the surgeon has seen the patient, okay, and the doctor would say another 1 month, another month, another month. We have no control over that, despite the fact we already gave doctors our assessment. I mean, we have no control as to the doctor portion.
What I would do is I would talk with your medical director to have conversation with the other nephrologists in the unit and with the surgeon to say that waiting and waiting and waiting for months and months and months isn't appropriate. That if the staff feels that the access is ready to cannulate, then they should, either the vascular access manager or the nurse, call the nephrologist and get the permission then and there and say that we believe that this is ready to cannulate. And then about making the appointment for the surgeon, they should have an appointment at the time that they have their surgery created. They should have a follow-up appointment already made. And it needs to be made at least 4 to 6 weeks out. And if it's not made when the patient comes back in the clinic, in the dialysis clinic, then your vascular access manager should call and create that appointment right there and then so that there's no waiting to get back in to see the surgeon.
Yes, we do that. We follow up on appointments, but then appointments takes forever. Backlogs and stuff, and we have no, and for the whole, for example, it will be scheduled in a month's time, we have no control over that. So what would happen is it would really prolong our, the catheter being there and the usage before we could even use that arm. We have no control. Those are the number one blockage we have in our unit. And because we have multiple surgeons that we don't have like a centralized surgeon referral or something like that. They have their own doctors, have their own surgeons that they refer to, and so different doctors have different appointment settings, and we cannot do anything until the patient sees this surgeon.
Again, I tell you, you need to have communication with the interdisciplinary team. There needs to be a big meeting, and you need to say, these are what we need for our patient, and you need to see if you can make it happen. And that's probably going to happen on the physician level, not on the nurse level at the clinic. But, you just need to sit down and try to figure out a way that the surgeons can get our patients in for follow-up. Follow-up shouldn't take, an hour of their time. And so, some surgeons have blocked out certain times where they only see their fistula patients for follow-up. And, and if it's too cumbersome for them, then they need to give up being the one that releases them for cannulation. So, you need to keep working on it. All right, well, if there are no more questions, I want to thank everyone for participating. If you've had more than one person at your site, if you could send me an email and tell me who your other people were that were with you, I would appreciate that. And thanks again for joining us.